Moving on to the muscles that move the pectoral girdle. In order to optimize the position of the hand in space, the scapula is capable of moving around the chest wall, and it moves in varying directions. It can glide upwards, which is known as elevation. It can glide downwards, which is known as depression. The scapula can roll forward, can protract, or can go backwards where the two medial borders of the scapula come together. That's known as retraction. The scapula is also capable of lateral and medial rotation. Lateral rotation is where the movement of the inferior angle of the scapula moves away from the midline. This has the effect of rotating the glenoid fossa, the socket for the shoulder joint, upwards to give an additional range of motion. Movement of the shoulder girdle is important for normal upper limb functioning. It produces around 1/3 of the overall movement of the upper limb. The muscles that produce protraction, the primary muscle is a muscle called serratus anterior, and serratus anterior is often known as the boxer's muscle because it's a muscle that works hard to stabilize the scapula when people do press-ups, when individuals do press-up or push their arms forward. Consequently, boxers tend to have very developed serratus anteriors. It's situated on the lateral surface of the thorax, lying on the external surfaces of the upper 8 or 9 ribs in the mid-axillary line. The fibers pass backwards, lying under cover of the scapula before attaching to the medial border of the scapula. So, although we can palpate this portion of serratus anterior, the bit that's in the mid-axillary line, the posterior portion is buried underneath the scapula itself, so we can't actually get our hands onto it. The lower serratus anterior interdigitates with the internal and external abdominal obliques. It's supplied by its own nerve known as the long thoracic nerve, and a long thoracic nerve palsy invariably leads to winging of the scapula. This is where the medial border of the scapula lifts away from the thorax. Serratus anterior is assisted by this small muscle. It's also a digital muscle known as pectoralis minor, that has its proximal attachment on the outer surfaces of the 3rd, 4th and 5th rib. It passes upwards and attaches onto the apex of the coracoid process. It's supplied by the medial pectoral nerve roots C6, 7 and C8, and tightness of pectoralis minor invariably leads to a significant round-shouldered position. This is found very commonly in individuals who spend a lot of time working at computers or sitting at a desk with their shoulders hunched. The opposite movement, the antagonistic movement of protraction, is the movement of retraction. This is produced by a number of muscles, the first two of which we have here, rhomboid major and rhomboid minor. These are very powerful, well-organized small muscles. There's my rhomboid minor at the top here, arising from the spinous processes of C7 and T1. It passes downwards and laterally and attaches to the medial border of the scapula, roughly around the level of the root of the spine of the scapula. This is rhomboid major down here, attaching from the spinous process of T5 all the way up to T2. Again, fibers pass downwards and laterally, attaching to the remaining aspect of the medial border of the scapula. Nerve supply is from the dorsal scapular nerve root C5, and these are strong muscles that have the effect of drawing the two scapulae together. This muscle here, trapezius, has a complex action. This is trapezius. This is one trapezius, so the one on the opposite side, on the left-hand side here, has been removed. It's a large diamond shape or kite shaped muscle when we see the two of them together. The trapezius is functionally divided up into 3 sections: the upper fibers, the middle fibers, and then the lower fibers down here. The upper fibers arise from the base of the skull at the back from the medial third of the superior nuchal line. From a bony protuberance at the back of the skull here called the external occipital protuberance. Fibers arise from the ligamentum nuchae down here, and then from the spinous processes of C7 all the way down to T12 and the overlaying ligaments, the supraspinous and interspinous ligaments. The upper fibers pass obliquely downwards and forwards and attach to the posterior aspect of the lateral 1/3 of the clavicle. The middle fibers come straight across, attaching to the medial aspect of the acromion process, and then the lower fibers come up to attach onto the root of the spine of the scapula. So we've got these three sets of fibers all converging onto the clavicle and the upper lip of that spine of the scapula and medial border of the acromion process. Its nerve supply is directly from one of the cranial nerves, the 11th cranial nerve known as the accessory nerve, and it has a small nerve supply also from the anterior rami of C3, 4 and C5. When the whole of trapezius contracts, we get the net movement of retraction. If we have the upper fibers contracting in isolation, we'll get the movement of elevation. So here's the upper fibers here elevating the scapula. When we get the lower fibers contracting in isolation, we get the movement of depression. When the upper fibers and lower fibers of trapezius contract together, along with the lower fibers of serratus anterior, we get the movement of lateral rotation of the scapula. The upper fibers pull the lateral border, the lateral aspect of the scapula upwards towards the head. The lower fibers pull the root of the spine of the scapula downwards, and the lower fibers of trapezius pull the inferior angle forward. So we end up getting this lateral rotation of the scapula. In addition to the upper fibers of trapezius, there is a small muscle called levator scapulae that lies deep to serratus anterior. Here is levator scapulae arising from the posterior tubercles on the transverse processes of C1 all the way down to C4. Fibers come down and attach onto the upper medial border of the scapula. Its function is to elevate the scapula, as the name suggests, levator scapulae, and its nerve supply is from the dorsal scapular nerve. Depression of the scapula is brought about by the lower fibers of trapezius, but this is assisted by this large muscle here, latissimus dorsi, that we'll look at when we do the shoulder joint, and a tiny muscle that sits underneath the clavicle called subclavius. Here is a diagram showing lateral rotation of the scapula. So here's the upper fibers of trapezius attaching to the posterior aspect of the lateral third of the clavicle and acromion process. Here are the lower fibers of trapezius attaching to the root of the spine of the scapula, and here are the lower fibers of serratus anterior attaching to the costal surface, the anterior surface of the inferior angle. Here's the axis of rotation, and the net result is this rotation of the scapula. The inferior angle gets swung outwards whilst the acromion process gets lifted upwards. This type of movement is known as a force couple, and as this movement occurs, tension is developed in the coricoclavicular ligament, the conoid and trapezoid ligaments. And as that tension develops, the clavicle is pulled into a posterior rotation about its long axis. Lateral rotation is important to allow full elevation of the arm. Medial rotation is also a force couple. This time the inferior angle moves medially around the chest wall, and the force couple is produced by pectoralis minor, levator scapulae and the rhomboids, again working in opposite directions to create this rotational movement of the scapula itself. Medial rotation is a far weaker movement than lateral rotation. Clinically, we often talk about scapulohumeral rhythm. Scapulohumeral rhythm refers to the accurate and timely movement of the shoulder girdle with the shoulder joint. There should be a balance both in terms of magnitude and in sequencing. And if the magnitude of scapular movement is reduced, we will get an overall reduction of elevation of the arm or movements of the arm above the head. If the scapula moves prematurely, for example, you may develop impingement of some of the subacromial structures.